most common disease or most common complaint of our gastroenterology, and both in ER patients or in admission patients. So this is the most important issues of our field. I have a lot of things to talk, so we need to begin right now. So you have any questions, you can answer, you can ask online. This is my reference. Almost of it is come from current international guidelines. If you have any interest for full article, you can find articles on PPT site. First things is that how to make the definition and classification of gastrointestinal bleeding. We call GI bleeding. As you know that our GI tract is long.
বাবা তোমার কি ডিস্টার্ব হচ্ছে?
What? Okay. So we need to classify our GI tract, GI bleeding as 3 parts by different location.
তোমার রুমে কি করব?
PPT said, the first type is upper gastrointestinal bleeding, called UGI bleeding. That means the breather is from esophagus, stomach, and proximal duodenum. This is the most common type of GI bleeding. The second type is the lower GI bleeding. That means the breather is from colon. Okay. The third part is small bowel bleeding, well, SBB. That means the breather is from small intestine. We can further classify the upper gastrointestinal bleeding for 2 parts by its different etiology as non-variceal bleeding and variceal bleeding. Okay, so we have 4 parts of GI bleeding topics need to talk. We will talk step by step. At first, what is the most common complaint or most common symptoms for GI bleeding patients? I think the most important thing is change of stool colors. As the picture said, patients have healthy stools. His stool is brownish and formed. The second picture is called melena. As we can also call the terry stool. That means the stool color changed to black, soft, sticky with bad smell. That usually means that patients have upper gastrointestinal bleeding. The third picture is hematochezia. That means patients have bloody stool. Okay, these symptoms is most happen when patients have lower gastrointestinal bleeding. How about the small bowel bleeding? Maybe it's varied. It have different presentations because that the small bowel is longest, about the 6 millimeters. So if the breather is from the proximal part of intestine, it may be present as melena. Or if patient the breather is from distal part of small intestine, maybe he will present as bloody stool. Okay, but you have always to remember one thing: if patients have large amount upper gastrointestinal bleeding, maybe patient will present as bloody stool. That means patients have large amount of blood loss. You may keep in mind and go on treatment as soon as possible. How about the size of gastrointestinal bleeding? You will find or you will note it when physical examination. I think that you will see the patients have pale looking, pale conjunctiva, and patient maybe have fatigue, weakness, presentation. And if patients have lower blood pressure, maybe have consciousness change or short of breath. How about abdominal pain? Maybe patient have or patient have not abdominal pain. If patient has abdominal pain, maybe will similar to his location and his disease location, like that. Okay. When you do the physical examination, you need to check the most important things is that do patients have any shock of signs like tachycardia, low blood pressures, or dry skin. This table is from the ICU book, taught us how to predict the amount of blood loss. But I think this is a complex table and hard to remember. This is for you for further reference. Before we go on to next step, I think one more thing you need to realize that hemoglobin levels is not a good indicator for us to predict the severity of GI bleeding, because when acute GI bleeding, our blood will hemo concentration, so hemoglobin will drop. Later, maybe take hours. So hemoglobin is not always a good predictor for us to predict the GI bleeding severity. Okay, let's go on the most important part of our topic is non-variceal upper gastrointestinal bleeding. In these patients, a patient will present as melena, coffee ground vomiting, or bloody vomiting. The etiology of upper gastrointestinal bleeding is, as the table says, most common is peptic ulcer disease, including both duodenal ulcer or gastric ulcers, followed by variceal bleeding, esophagitis, gastric erosions, malleolus tears, or vascular malformations. What is the malleolus tear? That means you will find a laceration wound over the junction of esophagus and stomach. This disease usually found at patients with heavy drunk and post severe vomiting. The right side picture is a GAVE called gastric intravascular ataxia. This is one example of GI tract vascular malformations. How to approach a patient with upper gastrointestinal bleeding? I think you can do step by step. The first step is carefully history taking, including carefully physical examinations. Next, you maybe think which patients need fluid resuscitations, or which patients need to do blood transfusions, or when do I need to arrange the endoscopic study? Post that, which medicine can we give? Or if the symptoms go worse and worse, when do we need to call for help? Like all diseases are, the initial assessment of upper gastrointestinal bleeding is carefully history taking and physical examinations. Do patients have any signs of shock? You need to make awareness at the first time, okay? Including patients have short of breath, tachycardia, or shock of low blood pressure, okay? Next step, you need to carefully review the patient's past history or recent medication intake. Like if patients have cirrhosis, maybe you need to consider the patients is variceal bleeding, okay? Or if patients have recent take antithrombotics like aspirin, Provis, or NSAIDs, maybe this is a drug-related gastrointestinal bleeding. Or like that, patients have nowadays patients have a lot of chance to do the endoscopic surgery. So you need to realize that do patients have recent endoscopic surgery? Okay. Next, the most important thing is to keep patients' vital signs stable. So if patients have any signs of shock, your first step, not to treat the GI bleeding, is to stabilize the patients. That's including 3 steps, including one is keep airway free. As you know, if patients have large amount upper gastrointestinal bleeding, patients maybe have a large amount bloody vomitus. That will cause patients suffocation, aspiration. Okay, so you need to let patients airway free. If unstable, maybe you need to do the intubations. Next, if patients have unstable hemodynamics, you need to give patients like a crystalloid fluid resuscitation to let the patient's hemodynamic more stable. The next is you need to consider which blood component do we choose to give patients. You always need to remember things. Vital sign is always the most important and first step you need to treat. Second step, if patients have relative more stable hemodynamics, the next step is to risk stratifications for his upper gastrointestinal bleeding. We have a lot of scoring systems to evaluation. This is the example for you called Glasgow-Bradford scoring system. This is a useful scoring system to evaluation patients when he come to emergency room. We can evaluate by this scoring system for patients which one need to admission or do the endoscope. The parameters on PPT for you for reference. But you can see that it's complex to use. So, but you can use nowadays we have many apps to check that. This article is, for example, how to use the Glasgow-Bradford scoring system. This study is from the Lancet 2009. Showed us that if patients have scoring like 0, no one need admission or no one need emergent endoscopic therapy. Next, this is more current articles from GIE. Also show that if patients have blood score scoring less than 3, no one need urgent or emergent endoscopic therapy. Patients if have scoring less than 7, no one death or need to surgical intervention for his upper gastrointestinal bleeding. So this is my brief summary for you. You can check the patient's Bradford scoring. If patients have scored less than 1, maybe you can let patients discharge right now and follow up at outpatient clinic. If patients have scoring 2 and 3, because that patient's relative low risk, no one need to do the endotherapy. Maybe you can deflate the patient's endoscopy study maybe next week or next days. But if the patient's Bradford scoring is more than 7, you need to consider that patient is a relative high risk UGI bleeding patient. You may need let patients admission and consider urgent or emergent endoscopy for him or she less than 24 hours. The third step is that when do we need to give patients blood transfusion? This is the famous article for us from NEJM that the transfusion strategy for UGI bleeding patients. It separates patients into 2 parts. One group is called restrictive strategy. That means we do the blood transfusion if patient's hemoglobin less than 7. Another group is liberal strategy. Is means that we give patients blood transfusion if hemoglobin less than 9. This is the result. We can see that the restrictive strategy, that means patients have blood transfusion less than hemoglobin less than 7, have better outcome than liberal strategy. The outcomes parameters including survival rate, rebreathing rate, and adverse events all show that the restrictive strategy is more better than liberal strategy. So this is my brief summary for transfusion strategies. If patients have stable hemodynamics, I think it's reasonable to give patients blood transfusion if patient's hemoglobin is less than 7. But if patients have unstable hemodynamics or patients have underlying coronary artery disease, maybe you can give patients blood transfusion earlier. Okay, then if you stabilize the patient's condition, the next step always the esophagogastroduodenoscopy. We call panoscopy or EGD. Okay, because the EGD can find a definite bleeder and evaluation the bleeding severity and make a definite diagnosis. For example, if patients have malignant ulcer like gastric cancers, you can take biopsy. And if patients have the ongoing bleeding, you can do the endoscopic hemostasis therapy for patients. This is an example for our EGD report. If patients have peptic ulcer disease, we can describe the patient's ulcer's severity like the table says. We can separate 3 parts like active ulcers, including A1 and A2 ulcers, healing stage ulcers, H1 and H2, or ulcer scar. The definition of the classification is as the table says, but I know maybe hard to remember, but I think there's a reference for you to understand how the EGD report state. You only thing you need to know is that active ulcers always means that patients have more severe ulcer disease. If patients have active A1 ulcers, that means patients have ongoing ulcer bleedings. So we need to more detail to describe the ulcer's disease. We can use the Firth classification for these active peptic ulcers. Like the picture says, Firth classification 1A means that patients have spurting ulcer bleeding. 1B means patients have active oozing. 2A means patients have vessels without active bleeding, as the pictures. Why the first classification is important in EGD report? Because that we can see the tables, the different first stage, that means patients have different rebreathing rate and patients have a different outcome. So if patients have higher risk first classification, like 1A, 1B, 2A, 2B, that means patients have higher rebreathing rate, more than maybe 30% or 50%. That means patients, you need to more awareness that, and maybe you need to keep patients without meal more times and more observation in ER room or admission. Okay, if patients have high risk ulcers or ongoing bleeding ulcers, we can do the endoscopic hemostasis therapy for patients right on time. these three pictures is an example for us to use the endoscope therapy. First is the injection therapy. We can use the injection needles, that injection epinephrine or sclerosing agents for the ulcer base. The second one is that we can use the thermal probe, like the APC or golden probe for the patients have active oozing vessels or active oozing wound. The right side pictures is mechanical clipping bleed method. Is that if patients have big wound or big vessels, that we cannot use thermotherapy. We can use the clipping. As you see, this is the mechanical clipping and most useful way to us to treat the high risk peptic ulcer bleeding patients. Okay, the last step is all the things we done. Which medicine can we give for these peptic ulcer disease patients? As the table says, if we want a bleeding stop, we always need the platelet help. And higher pH in gastric volume is promote a better platelet function and clot stability. And so our target for peptic ulcer disease treatment is to raise the intragastric pH levels. The previous study also showed that if we want to prevent the stress ulcer bleeding, we need to raise intragastric pH more than 4. If we want to prevent the recurrence of peptic ulcer disease bleeding, we need to raise the intragastric pH levels more than 6. So the most useful medication for peptic ulcer disease is anti-acid agents. Nowadays, the most common use for medication is H2 blockers and proton pump inhibitors. Two kinds of these agents are to inhibit the acid secretion in our stomach. As the previous study say that the more common proton pump inhibitor compared to traditional H2 blockers, it has the better intragastric acid control. And the PPI, we call proton pump inhibitor, called PPI, can reduce patients' rebleeding rate and reduce the rate of surgery and death. So nowadays, the first line and most potency medication for peptic ulcer disease is proton pump inhibitor, called PPI. Okay, let's go on the second part of GI bleeding is variceal bleeding of upper gastrointestinal bleeding. Almost, I think it's almost not all. The variceal bleeding is come from patients with cirrhosis because that the cirrhosis will induce portal hypertension, then will cause the venous engorgement over esophagus and stomach. That causes varices formations, like the picture said. These two pictures is the real pictures over endoscope, show the varices formation. The left side is EV, called esophageal varices. The right side is GV, that means gastric varices. We can further classification of varices like the GOV or IGV. The upper picture shows GOV. That means patients have both gastric varices and esophageal varices. The most common type is GOV1. That means the gastric varices is creation from the lesser size of stomach. The lower picture is IGV. That means isolated gastric varices. That means patients have no esophageal varices and have only gastric varices. You can see that IGV2 on the right side and lower part of our pictures have 4.2% patients have IGV2. If patients have IGV2s, maybe you need to think about that's more different come from the cirrhosis. These patients always have splenic main thrombosis, and it comes from pancreatic cancers or pancreatic tumor. You need to remember that. Unlike the peptic ulcer disease, the endoscopic therapy for varices bleeding is, as the picture said, we can do the varices bleeding stop by ligation. It's almost more useful for esophageal varices. And we also can injection the sclerosing agents like hydroxyacryl for patients' varices. The sclerosing therapy is more useful in gastric varices. How about the medications after the esophageal varices ligation or gastric varices sclerosing therapy? What medication can we give for patients with variceal bleeding? Because patient varices formation is vascular lesions. So after the endoscopic therapy, we can give patients vasopressors. The evidence shows that if we combine vasopressor use, patients have better bleeding control. Okay, next we'll go on the third part of bleeding called low GI bleeding. That means the bleeder is from colon, proximal side, distal to IGV, iliosarcophagus, and proximal to anus. Okay, let's call low GI bleeding. Patients with low GI bleeding, most common symptoms is hematochezia. That means patients have bloody stool. That's more common. But if patients have more chronic or more proximal side colon bleeding, maybe patients also will present as terry stool. Okay. If patients have rectal bleeding, we will think that means patients have brownish stool, a normal color stool, but have blood tinges on it. Maybe we will think the first diagnosis is anal bleeding, like hemorrhoid bleeding, or anal fissures, or anal ulcer bleedings. Unlike the upper gastrointestinal bleeding, low GI almost more than 6% patients with low GI bleeding will stop spontaneously. Okay, that means that maybe not high risk patients, but you need to consider patients. If patients have red flag sign, you need to more awareness of these patients. For example, if patients have more elderly or previous GI tract surgery, or patients have significant body weight loss, or patients have a lot of multiple comorbidity, multiple medication use, okay? Or if patients have previous IBD disease called inflammation bowel disease, including Crohn's disease or ulcerative colitis, because IBD patients maybe have severe bleeding episodes, and also IBD patients also had high risk for colon cancers. So if patients have IBD history, you need to more awareness about these patients. The most useful tools and accuracy tools for low GI bleeding study is colonoscopy, as we know. Okay. How about the etiology of low GI bleeding? As the table says, about half patients are diverticulitis and diverticulum bleedings, followed by ischemic colitis, hemorrhoid bleeding, or colorectal cancers, angiectasia, or patients just post a polypectomy bleeding, or the less common is IBD or infectious colitis, like the salmonella colitis, like that. What is the diverticulitis? I think that is the next issue for us. But diverticulum means that patient's colon have a punch out spaces because have the weak muscle layer, and if this space got inflammation, infection, they will got infection like the diverticulitis, and the diverticulitis may cause GI bleeding. The most common site of diverticulitis bleeding is squamous colon. The next etiology is ischemic colitis. That means the patient's colon have unsuitable blood flow for it and got ischemia. If the colon got ischemia, it will have the deep ulcerations and cause GI bleeding. This disease is most common from the elderly patients, or patients have shock status, or patients have underlying vascular disease like coronary artery disease, peripheral vascular obstruction disease, heart failure disease, or patients is ESRD patients. Those patients maybe have higher risk for ischemic colitis. And the most common site for ischemic colitis is the watershed area over colon. That is most two common part is squamous colon and splenic fracture of colon, like the pictures said. These pictures is about the inflammation bowel disease. You can see that these pictures is from the colonoscopy. You can see that patients have diffuse hemorrhagic spots, ulcerations, and inflammations. I think the IBD is another issue for us, but we don't have time to more detail about IBD. But you can see that the IBD is may cause severely low GI bleeding. So if patients have history of IBD, you need to more awareness of these patients. The next, you always remember that colon cancers, because as you know, the colon cancer is most common cancers, have the most common cancers have higher prevalence in the world. So if patients have intermittent bleeding, you always and patients have elderly or colon cancer history, you need to take awareness about patients maybe its bleeding is from the colon cancers. As pictures, the most common site of colon cancer happen is about rectum, followed by squamous colon and secant. How about the management of lower GI bleeding? If patients have large amount acute lower GI bleeding with unstable vital sign, maybe the colonoscopy is not suitable tool for it. Even though a colonoscopy is more accuracy and more useful. But if patients have large bleeding without a well-prepared we cannot see anything when we do the colonoscopy, because that if we want a high quality of colonoscopy, even patients have acute bleeding, we need to do the colon prepared by laxative agents. So if patients have emergency condition, the colonoscopy is not a suitable tool. So if patients have a life-threatening condition, the useful tool for us is do the CT angiography, and we can find the acute blood loss and find a bleeder from the vessels. And if we can find it, we can do the embolization on time and on the right time. So if patients have intermittent low GI bleeding, you can do colonoscopy after the well colon prepare for patients, okay? But if patients have life-threatening or large amount bleeding, or patients is under the unstable condition, the colonoscopy is not a suitable tool for patients. The most useful way to help patients is CT angiography and embolizations. Okay, next we will go on the next, the final topic for us is small bowel bleeding. The small bowel bleeding have many terminology before, like the obscure GI bleeding, or because that it's hard to find out the bleeding, because we know that the small bowel is long as 6 meters, so it's hard to find out. Okay, but nowadays we all call the bleeder from small intestine called small bowel bleeding, not the middle GI bleeding or obscure bleeding. That means the small bowel bleeding is the bleeder is distal to ampulla vata and proximal to ileocecal valve. Okay, that means the bleeder is from small intestine. In these patients, we always do the esophagogastroduodenoscopy and colonoscopy, which all show negative finding. And if patients have ongoing bleeding, okay, we maybe suspect that patients have small bowel bleeding. The most common etiology of small bowel bleeding is angioectasia, as the picture over right side. Angioectasia means that one example for vascular malformations. And the angioectasia is more common in ESRD patients. That means patients have chronic kidney failure under hemodialysis. So these patients will have higher prevalence of angioectasia. So if patients have intermittent small bowel bleeding, and patients have chronic kidney failure, we can suspect that patients have angioectasia bleeding over small intestine. Other cause of small bowel bleeding is IBD. That means IBD is Crohn's disease, not ulcerative colitis, because ulcerative colitis is located over large intestine, okay? Followed by duofoid lesions, neoplasia, that means small bowel cancers. Even though the small bowel adenocarcinoma is not is under the lower risk, but you always need to keep in mind that maybe patients have small bowel cancers. If patients have another symptom like bowel obstructions, okay? Followed by NSAID users or polyposis syndromes. How about the presentation of small bowel bleeding? Like we said, due to the small intestine is long, so patients' presentation of small bowel bleeding can be present as melena or hematochezia. Just depend on lesion site. If the bleeder is more located over proximal intestine, like jejunum, maybe patients will present as terry stool. But if patients have lesions is over distal intestine, like terminal patients will present as bloody stool. And sometimes patients will present melena and bloody stool and change on times, maybe have both symptoms for us. And because maybe the small bowel bleeding is obscured, some patients will found the small bowel lesions only because patients was found have unexplained iron deficiency anemia when healthy exam, because that the bleeding is minimal, so patients cannot found in the stool color change. So patients will refer to our clinic by hematologist because unexplained IDA. So especially for male patients, because that if patients have unexplained IDA in male, we always think that patients have obscure GI bleeding and need to exclude GI tract malignancy first. How about the diagnostic tool for small bowel bleeding? I think it's more complex than upper gastrointestinal bleeding and low GI bleeding. That's it because small bowel is long and hard to approach. Deep endoscopy means the 小肠内视镜, just we do the endoscope into the small intestine, but it's more harder than EGD and colonoscopy because that do the deep endoscopy is uncomfortable and more risky, and almost patients need to do the deep endoscopy under general anesthesia. So we have others alternative tools for small bowel bleeding diagnosis. By the international guidelines, the first line tool for us to evaluate the small bowel bleeding is a video capsule endoscope because it's safe and more patients have more discomfortable and more safe way to do that. But as you know, the video capture endoscopy is expensive. So I don't know. I think first line to do a small bowel evaluation tools is different from countries' guidelines. But by the US guidelines nowadays, video capsule endoscopy is the first tools for small bowel bleeding evaluation because it's safe and without uncomfortable. But if patients have ongoing bleeding, maybe patients have chronic melena or chronic bloody stool for a long time, and you think that you need to do the evaluation, the location, and do the treatment immediately, maybe you can choose deep endoscopy for the first tools to do, because that you can treat like the previous endoscopy therapy, it can do right on time. Okay, so I think that if you want to do the deep endoscopy as the first line, you can consider cases with ongoing bleeding, or patients have contraindication for video capture endoscopy, like a patient have severe small bowel stenosis history before. The third tool for us is the CT enteroscopy, called CTE. CTE also is an expensive study for us. So CTE should be considered in patients with small bowel bleeding but negative video capture endoscopy study. You can do the CTE for further evaluation and to guide the next deep endoscopy study. Okay. Also, if patients have IBD history, or you think patient had high risk for GI tract stenosis or post radiotherapy, you afraid of the endoscopy related GI tract perforation, you can do the CTE as the first line therapy for these patients. As we taught before, if patients have large amount and life-threatening small bowel bleeding, we taught video capture endoscope, endoscopy, or CTE, or is not our choice. If patients have large amount of overt and life-threatening small bowel bleeding, the first line management and diagnostic tool is CT angiography. Okay, we can do the multi-phase CTA to identify bleeder and do the emergency angiography for unstable patients. Okay, so if patients have ongoing and overt GI small bowel bleeding, the first line management is CT angiography. Okay, our talk is over, and I think because the GI tract is longest organ in our body, so I only can do the simple description of the different kinds of GI bleeding and some recommendations for you to, if you meet the GI bleeding patients, what can you do at the first time, and next step approach, then the management and study. Thank you. Do you have any questions? Okay, someone says that the slides will stop. I'm sorry, but our computer is normal ongoing, so I'm sorry for that. Okay. One guy asked that, can we have the access to the slide? Yes, we will give you the slides for you. Okay. Because we have, I think that we have no more questions, so we will close these sections. Okay, take a rest, and we will go on next topic on 9 o'clock, right? Okay.
Thank you, Professor Yao.
Would you like to ask how to do? I think that SD tube is not used in Taiwan. So if the patients have emergent conditions and patients cannot approach the emergent endoscope, you can use the SD tube. But in Taiwan, because Taiwan is small and we always have the emergent endoscopy on call 24 hours, so I think that a steel tube is not useful in Taiwan. But I think that is by different countries, because if the area could not have the emergency variceal ligation, maybe patients can use the SD tube for initial treatment. Then the patients will revert to the hospital who can do the endoscopy for the patients. So if patients have emergency variceal bleeding and patients cannot get the right time endoscopy, we can use the SD tube for resuscitation. Okay, thank you for everybody.
Okay, maybe we will have 5 minutes break, and after that we will have the other tutor, Dr. Wang, to have the other session.
Hi, good
for us.
morning. Can you hear my voice?
Yes.
Okay.
Yes,
I'll
we
prepare
can.
my slide first. Okay, I guess we'll start in 5 minutes then. Okay, good morning, everyone. Shall we start the next session now? Okay, good morning, everyone. I am Calvin Huang Zixin from Kaohsiung Zhangkong Memorial Hospital. And today, I will be sharing with you about some topics in hepatology, and mostly I'll discuss with you about abnormal liver function tests and some associated diseases and conditions that you might want to look out for when you first approach clinical patients. Okay, so let's first talk about some common liver function tests you perform for the patients. Aminotransferases, AST and ALT, these are the most common, and AST and ALT mostly indicate hepatocellular injury. AST and ALT are both present in primarily in the liver, but AST is also seen in other organs such as cardiac muscle, skeletal muscle, kidney, and brain. So AST is less specific for hepatocellular injury, and you may even see it elevated in heart failure or myocardial infarctions. And other function tests are alkaline phosphatase, ALKP, and gamma glutamyl-transferase, gamma-GT. Serum alkaline phosphatase is predominantly from the liver and the bone. So alkaline phosphatase may be elevated as well in some diseases involving the bone. And gamma-GT is a little bit more specific for the hepatocytes and biliary epithelial cells, but it may also be found in other organs as well, such as the kidney, pancreas, spleen, heart, and brain. Gamma-GT may also be elevated in patients who are taking some medications, such as barbiturates, phenytoin, or in patients who have alcohol use disorder, who have take large amounts of alcohol, drink large amounts of alcohol. It may also be elevated in patients with diabetes and COPD. So gamma-GT is more specific to hepatocyte and biliary cells than alkaline phosphatase, because alkaline phosphatase, there are other subtypes such as the bone alkaline phosphatase, but it is also may be elevated in other causes as well. Okay, and these are more liver function related: bilirubin, prothrombin, and albumin. Bilirubin is a catabolic product of heme metabolism, and then when from the bloodstream, it goes into the liver and gets conjugated. So there's conjugated type of hyperbilirubinemia, which may be elevated in hepatobiliary disease, and maybe also unconjugated, which may be related to a more wide range of diseases. For example, hemolysis, there may be unconjugated hyperbilirubinemia, but if the disease of unconjugated hyperbilirubinemia is related to the liver, then it may be related to impaired liver uptake of the unconjugated form. Okay, and PT and albumin, these two reflect the liver function of synthetic function, because these are the coagulation factors, and albumin are produced in the liver. So when you look at these and you see a patient with hepatocellular injury, AST has a half-life of 1 day, the ALT has a half-life of 2 days, and the PT prothrombin time has a half-life of 4 to 6 hours, and albumin has the longest half-life of about 20 days. So when you look at these and a patient suffers from acute liver failure, the first to reflect the disease would be prothrombin time, and then AST will become markedly elevated, followed by ALT. Albumin may be normal if the patient suffers from acute liver failure at the time of presentation, but after a few weeks, because of the decreased synthetic function, albumin will gradually decrease as well. So we can group these function tests into two groups. One is the marker of liver injury, and we commonly call these AST, ALT liver enzymes. So they reflect the damage to the liver or the biliary obstruction. Albumin and prothrombin time, they reflect the impaired liver function of synthetic function, and bilirubin may reflect both liver injury and hepatocellular function. This is for your reference. These are some of the reference ranges for the normal. Usually you can memorize these as AST, ALT upper limit is 40, and alkaline phosphatase is up to 100, and gamma GT is up to 50, up around that range, because reference values vary from lab to lab. So you might want to check your where you practice what the reference ranges are. Okay, so let's talk about when you approach the patient and you see his lab data, what do you want to identify? These are the most common patterns of hepatic injury seen in the patient. And first of all, there's the hepatocellular pattern reflecting hepatocellular injury. And this is shown as with a very, very more highly elevated AST, ALT levels, with bilirubin and alkaline phosphatase both slightly elevated or normal. And when you see another pattern is a cholestatic pattern. Cholestatic pattern means that the bilirubin and alkaline phosphatase are both markedly elevated. And the AST, ALT may be slightly elevated, or they may be normal as well. And when you see an infiltrative pattern of disease, the AST, ALT are near normal, and the bilirubin may be normal as well or slightly elevated, but the alkaline phosphatase is very, very highly elevated. Last but not least, there is isolated hyperbilirubinemia. Isolated hyperbilirubinemia is defined as a normal AST, ALT, normal alkaline phosphatase, and only elevated bilirubin. So here's a mnemonic for you to, for those who like mnemonics to memorize the disease etiologies. There's A, B, C, D, E, F, I, M. And these are some common causes of hepatocellular injuries. So if you like to use mnemonics to memorize things, you can try this one out. A may be related to hepatitis A or autoimmune hepatitis. B may be related to hepatitis B virus or biliary hepatitis. C may be due to hepatitis C virus or congestion. D may be due to drug-induced liver injury. E may reflect ethanol, alcohol use. And F is fatty liver, NASH, for example, non-alcoholic steatohepatitis. There's another disease called NAFLD, non-alcoholic fatty liver disease. We'll mention that shortly. And I is for ischemic hepatitis. This is vascular causes or hemodynamic related. And there's M, metabolic diseases such as Wilson's disease, hemochromatosis. These are all possible causes of hepatocellular injury. So when you approach a patient with abnormal liver function test, you have to ask some questions when you're doing the history taking. And these are, as I mentioned on the previous slide, some of the key elements that you want to know to determine the etiology of the liver cell damage. First of all, alcohol. So what is clinical significant alcohol consumption? For males, it's over 210 grams per week, and for females, it's over 140 grams per week. This is clinical significant alcohol consumption. So if you take this, for example, this can of beer actually contains about 15 grams. So clinical significant alcohol consumption, 210 grams means 14 bottles per week for a man. And for a female, it's about 10 bottles a week. If you exceed that limit, then that's clinical significant alcohol consumption and may contribute to the patient's liver damage. And as previously mentioned, any or all medications may have hepatotoxicity. So when you take the quiz, take history, you want to ask if the patient is taking any medications regularly, or maybe they took some new medication. And past history of viral hepatitis B or C is very important. If the patient has DM, metabolic syndrome, or heart failure, these are also some etiologies of hepatocellular injury. There's also travel history. For example, there are diseases that are only more prevalent in endemic areas, and if there is really recent travel history, such as to areas where there is poor hygiene, then there may be hepatitis A or rickettsia, such diseases that need to be considered. And family history is kind of like past history, because we all know that viral hepatitis B may be perinatally transmitted from mother to child. And last but not least, there is constitutional symptoms for all patients. And here are the constitutional symptoms for liver disease, such as fatigue, tea-color urine, abdominal pain. There may be dyspnea or leg edema due to hypoalbuminemia, etc. So these are some important questions that you want to take when you're approaching a patient with a liver injury. Okay, so we did talk about any or what kind of medication the patient may be taking. And here are some of the more well-known drugs that have hepatotoxicity that you might want to look out for. Acetaminophen, this is a very, very common over-the-counter drug. And however, you don't need to worry about this too much because this is a very high dose related hepatotoxicity. It will usually take up to over 10 to 15 grams of acetaminophen to cause liver injury. And usually you only take one pill at a time, and each pill contains only 0.5 grams of acetaminophen. So usually this is intentional swallowing a bunch of pills that may cause such severe hepatotoxicity. Another drug is amiodarone. Amiodarone is a very common drug used in arrhythmias, for example, atrial fibrillation. It might cause drug-induced liver injury in some patients. And another very, very famous drug that causes hepatotoxicity is anti-TB drugs such as isoniazid and rifampin. Other diseases, other antibiotics such as augmentin and erythromycin are commonly prescribed, but may cause hepatotoxicity in some patients. And also the antifungal agents are metabolized in the liver as well. So these may cause hepatotoxicity in some patients as well. And anticonvulsants, phenytoin and valproic acid, these you have to use with caution in patients who have impaired liver function. And a very, very commonly prescribed drug is statins. And statins are very commonly prescribed nowadays for hyperlipidemia. And these drugs also may induce liver injury. So if you prescribe statins, usually the doctor arranges regular follow-up of liver function tests at the outpatient department. Okay, so we talked about the history and we talked about some commonly known drugs. So let's talk about the values and the AST-ALT ratio and the magnitude of elevation, how you can interpret these tests and determine the etiology of the patient's disease. For example, when you talk about alcoholic hepatitis, the AST-ALT is usually, usually a hepatocellular pattern. The AST-ALT is elevated, but usually in alcoholic hepatitis, the AST is more elevated than the ALT, up to a ratio of over 2 to 1. This is especially noted when the gamma GT is elevated as well. As I had previously mentioned, the gamma GT may be elevated in a patient who has chronic alcohol use disorder. And as for the magnitude of AST-ALT elevation, the alcoholic hepatitis usually it exceeds the upper limit, but usually if it's purely related to alcohol, the hepatitis with AST-ALT levels may be usually less than 500, about like 10 to 15 times the upper limit of normal. Another important etiology is other important etiologies are viral hepatitis, NAFLD, non-alcoholic fatty liver disease, and NASH, non-alcoholic fatty steatohepatitis. These cause hepatocellular injury as well, and the AST-ALT, on the contrary, is usually ALT predominant. Usually it's AST equal to ALT, or ALT is slightly more elevated than the AST. And in NAFLD is a rather slightly more mild disease than NASH, and usually the AST-ALT elevation is usually less than 4 times the upper limit of normal, so it's usually less than 200. So that's probably, you may explain the AST-ALT ratio by using NAFLD as the etiology if it's really not that elevated, but you need to work up other causes as well. So what happens if you see acute AST and ALT elevation over 1,000 units? So it's over 25 times the upper limit of normal. Okay, here are the possible and more commonly seen etiologies for acute AST/ALT elevation, for example, viral hepatitis, the ischemic hepatitis, drug medication-induced liver injury, autoimmune hepatitis, and metabolic diseases. So, and I listed here that in ischemic hepatitis, often the AST/ALT elevation is very, very high, up to 50 times upper limit of normal, and associated with a high serum lactate, which reflects that the patient has hypoxia. So here's a table from the Massachusetts General Hospital Handbook of Internal Medicine, which gives you a brief view of the patterns of hepatocellular injury. This is for your reference. We will talk about the clinical cases and diseases next. So there might be some questions, and you can type them into the chat. For this one, this is the first case. This is a 45-year-old man who we recently traveled to India. Well, we know that now there is COVID. Probably you would guess that probably the guy has COVID first, but this is probably, for example, not during a COVID pandemic. And the patient returns and visits your clinic and has symptoms of fatigue, malaise, poor appetite, jaundice. And physical examination only shows slight hepatomegaly. And the lab data you follow up, you see this data. AST is 285, ALT is 325, bilirubin is 1.2, alkaline phosphatase is 105, and PT is 9.5 seconds. So what type of hepatic injury is found in our patient? This is, I marked the abnormal values as red. So what kind of hepatic injury is found in our patient? I'm pretty sure you all can tell that this is a hepatocellular pattern because only the AST/ALT are elevated, and other bilirubin and alkaline phosphatase is normal. So I introduced you to a mnemonic previously, but here is a hepatocellular pattern summarized by the etiologies of possible causes. The hepatocellular pattern injury may be caused by viral hepatitis, and there are all kinds of hepatic viruses such as hepatitis A, B, C, D, E, and other viruses that are that may cause hepatitis, but not specific for liver, not specific for the liver, such as CMV, EBV, and the HSV. And autoimmune hepatitis causes hepatocellular injury. And what do you need to check if you want to see if the patient has autoimmune diseases? That would be ANA and the anti-smooth muscle antibody. And drug and alcohol substance-induced hepatitis, steatohepatitis such as NAFLD or NASH, and vascular causes such as congestive liver or ischemic hepatitis, and metabolic diseases such as Wilson's disease, hemochromatosis. And for Wilson's disease, you will have to check for copper, urine copper, and the serum ceruloplasmin. And for hemochromatosis, you might want to check iron, TIBC, ferritin, or arrange a liver MRI for evaluation. So back to our patient, when you test, you might want to test for hepatitis viruses first, right? And when you check for the IgM of anti-HAV antibody, it shows a positive result. So as you all might know that IgM is for the acute phase, and anti-HAV IgM antibody positivity actually just simply indicates that the patient is a patient with acute hepatitis A. So this patient, we probably have the impression of acute hepatitis A. Okay, so that introduces us to another topic, the viral hepatitis. Let's talk about the hepatic viruses A, B, C, D, and E. HAV, as we had just mentioned, and HEV, these two viruses are transmitted enterally, so it's a fecal-oral transmission disease. And these two are acute hepatitis. These two cause acute hepatitis. And the HEV in Taiwan, we have to send it to the CDC. So we cannot test for antibodies or antigens. And anti-HAV, as I just said, there's IgM and IgG. IgM is the acute phase, and IgG is there will be anti-HAV IgG once the patient is exposed. So IgM is the diagnostic marker for acute hepatitis. And as for the other viruses, HBV is a DNA virus. This is very important. All the other viruses are RNA viruses. So this is a major problem for why currently we can eradicate HCV, but HBV, the DNA is integrated in the host. So there is a difficulty in current medical treatment to totally eradicate HBV from the body. So HAV and HAV are fecal orally transmitted, and HBV, HCV, and HDV are mostly transmitted from the blood. And as for chronicity, the HBV virus is mostly acute, actually. So you see here that I say that HCV is 70% chronic. So once a person is exposed to the HCV virus, only 30% recover spontaneously, and 70% become chronically infected with the HCV virus. And the HBV virus, up to 95%, 90 to 95% of the patients exposed to the HBV virus will recover spontaneously, and only 5 to 10% of these patients, once initially exposed to the HBV virus, will become chronic carriers. So the HCV, if you check for the antibody, it will be positive if the patient has been exposed to the HCV virus, but it will always remain positive. So this is not a diagnostic marker or a protective antibody. It just indicates that this person was once exposed to the HCV virus, but you need to check if the RNA is present to determine if the patient is still actively infected with HCV, chronically actively infected. And the HBV is very well known with many, many kinds of antigens and antibodies. We'll talk about this here. There are several kinds: the HBs, surface antigen, surface antibody, the HBe antigen, the E antibody, and the core HBc antibody. Here is a typical course of the HBV infection. Acute infection, once a patient is exposed to the HBV virus, and this patient is the 90 to 95% of the 95% of the population who recovery after exposure. The HBs surface antigen is a protein on the surface of the hepatitis B virus. So you're exposed, it is in your body, and during acute infection, the level is high. It rises as the virus replicates in your body. So the presence of HBs antigen also indicates that the person is infectious. Okay, next, this person is infected, and the HBe antigen, the E antigen is usually means the virus is actively replicating. And HBe antigen is here, as you can see, this is a very short period of HBe antigen positivity, and then the body develops the anti-HBe antibody. So usually when the anti-HBe comes out, it means that the virus has stopped replicating actively. So here, as you can see, the patient is in recovery as well. So the HBs antigen gradually decreases, and the HBe antigen becomes negative, and anti-HBe antibody comes out. And then when you see here, this is the same as the HAV antibody. The IgM is still the acute phase. So during the acute phase, IgM anti-HBC rises and then gradually decreases as the patient recovers. But the IgG, or the total anti-HBC, remains high after exposure to the HBV virus. And after about 8 months or so, this is later after exposure, here the human body produces the anti-HBs, the surface antibody. The surface antibody means that the patient has recovered from the HBV infection, and the patient is now immune to HBV. So anti-HBs means immunity. Okay, here's the same graph, but this is a patient, the 5 to 10% of patients who become chronically infected by HBV. This is here you can see I've shown, this is a quite important thing. The patient is defined as acute hepatitis if the HBe and HBs antigen is positive for over 6 months, for less than 6 months. But if it exceeds the 6-month period, you can tell the patient that the patient has been chronically infected. He is a chronic carrier now, if the HBs antigen is positive for over 6 months. Here you can see for chronic infection, HBs antigen rises, indicating the virus is replicating as well, and HBe antigen remains positive. And after years, maybe your immune system is able to shut it down a bit so that HBe antigen will turn negative and anti-HBe antibody will come out. But the HBs antigen remains positive as long as the patient is chronically infected. And here, the IgM anti-HBC decreases after the acute phase. The total anti-HBC remains positive after exposure to HBV, but this patient does not develop immunity. The patient does not develop anti-HBs antibody. So this person does not have recovery, does not have immunity, and this patient is chronically infected by HBV. That was the horizontal transmission. This is a vertical transmission. For example, a child who is born to a HBV mother with HBV. So HBV DNA is usually very high if the child is initially vertically transmitted, perinatal transmission. And then after about 20 years, the patient may have episodes of hepatitis. This is traditionally called immune clearance, immune reactive phase. And this is when the body tries to clear out the HBV. And this is when the liver, the hepatocyte, is generated under very severe inflammation, and inflammation may cause fibrosis. And fibrosis will lead to the consequently cirrhosis and HCC at later years. So there are other issues as well, for example, reactivation or other types of causes that may cause acute hepatitis during these periods. But that is another very, very big topic, and it's for another time. This is a newer interpretation of the horizontally transmitted diseases. This is from the Europe guideline, and they give the phases different types of names for better to define these phases more easily. So they just divide the patient into HBe antigen positive patients or HBe antigen negative patients. This is the marker for high viral replication, right? HBe antigen indicates if the virus is actively replicating. So HBe antigen positive patients, they can have chronic infection with normal ALT or chronic hepatitis with elevated ALT. And DNA levels will be reflected as well. HBe antigen negative patients will have chronic infection with normal ALT as well, but sometimes HBe antigen negative patient will have hepatitis as well. And at these times, HBV DNA are also elevated. And this might be related to if the HBV needs treatment. Okay, so we talked about HAV and viral hepatitis. Let's approach the second case. This is a resident at your hospital and with a recent needle stick injury. He comes to you with fatigue, malaise, poor appetite, jaundice. So you see the same symptoms from this patient, but the history is different. He's a hospital worker, and right now you see that AST is 1,217, ALT is 1,600, and total bilirubin is slightly elevated, 2.8. Alkaline phosphatase is 174, and the PT is prolonged, 14.3 seconds. So we know now that this is a hepatocellular pattern. So what do you think of? Viral hepatitis. So viral hepatitis, anti-HAV IgM checked as the first case was negative. The HBs antigen is positive. The anti-HBC antibody is negative. And other causes such as acetaminophen level is normal. And we performed a liver echo, which showed only mild fatty liver. So does this mean that the patient has hepatitis B, acute or chronic? So if you want to determine if the diagnosis of hepatitis B is an acute hepatitis B, what further test is needed? Okay, I've listed the tests. All of them are abnormal, and but mostly it's a predominantly hepatocellular pattern, and the HBs antigen is positive. And what is the test that is needed for the diagnosis of acute hepatitis B? Okay, acute phase. Yes. Okay, very good. I see somebody already typed the answer there. Acute phase, you need to determine if the patient is acute hepatitis B. You need the IgM of anti-HBC. Okay. Okay, and this patient, the same patient, after followed up at your clinic, suddenly the HBs antigen turns negative. And you perform other workups such as serial plasmin to determine if the patient has Wilson's disease. ANA is negative, and the smooth muscle antibody is negative because he's a young male patient. You wanted to exclude if there is autoimmune hepatitis. So these are negative, but the HBs antigen turns negative. So is the patient not acute hepatitis B? This brings us back to this picture, this graph of the acute HBV infection with recovery. The HBs antigen and the anti-HBs before development of anti-HBs, there is a window period. So during this window period, what do you need to test for acute hepatitis B infection? Because the patient, if the patient was not our hospital worker with a clear history, the patient may present to you during this period of time as well. So this is a window period where HBs antigen is negative and the patient still has not developed the antibody. So during this window period, the only marker that can tell you that the patient has acute hepatitis B is the IgM anti-HBC, the core antibody IgM. This is the only marker that can tell you that this person has acute HBV. So here is another table from the Massachusetts Handbook. This is the interpretation and serologic and virologic test of HBV. And this will tell you if the patient is acute hepatitis in recovery or chronic hepatitis B. And this is reflects the marker, serial markers of S antigen, anti-HBs, core antibody, NGM or IgG, or E antigen and E antibody, and the HBV DNA. Okay, so our patient, after 4 months, the anti-HBs antigen turns negative, but the anti-HBC IgM is positive. So this patient, we can say that our impression would be acute hepatitis, but in resolution. Okay, so next, let's talk about a case who 72-year-old female patient. She is admitted to the hospital for urinary tract infection, but unfortunately septic shock develops, and on physical examination, you see that the patient requires inotrope support for a very hypotension. There's a blood pressure is only 92/64 millimeters mercury. And the lab data, you see a very, very high AST, 3,000/3,000. The ALT is elevated as well, very high as well, 1,800. And bilirubin is slightly elevated, 2.2. Alkaline phosphatase is elevated, 214. The PT is borderlinely elevated, slightly only, 11.3 seconds. Okay, so this patient also has hepatocellular injury, right? So anti-HAV, HBs antigen, anti-HCV, check for the viral hepatitis marker. The liver echo is done as well, only shows mild fatty liver. But the patient is treated for UTI. As you know, UTI, even though the patient has septic shock, but urinary tract infection for a patient who is without a very severe underlying disease or immune deficiency, usually is a relatively self-limited infection. So it can be treated more easily compared to other infections such as pneumonia or biliary tract cholangitis, such as these. So, and after the patient condition stabilized and treated well, the liver function test improves soon. So this patient, you can see very acutely, the AST/ALT is elevated, very, very high. And then this is a hepatocellular injury pattern. What is the most likely diagnosis? We mentioned hemodynamic instability. So pretty obviously, this patient probably has ischemic hepatitis related hepatocellular injury. Okay, let's talk about the next case, and this will bring us to our next topic. This is a 25-year-old female who was admitted to hospital for acute appendicitis. On the physical examination, you see that patient has icteric sclera. And on the lab data, you see that the patient seems to have anemia. The hemoglobin level is 9.5, MCV is 65, and the AST/ALT are mostly normal. The bilirubin, the total bilirubin is 4.2, and the direct type bilirubin is only 0.3. And alkaline phosphatase is normal and the PT is not prolonged. So this, as you can see, the AST, ALT, alkaline phosphatase are normal and only bilirubin is elevated. So this, by definition, is the isolated hyperbilirubinemia. And the direct type of bilirubin is not elevated. So this is an indirect type of hyperbilirubinemia. So this will bring us to the next topic, the bilirubin metabolism. Bilirubin is usually, you can see that from here, whether it's from intravascular or extravascular hemolysis, heme will be turned into bilirubin, and bilirubin is unconjugated bilirubin and albumin in the blood. So in the hepatocyte, unconjugated bilirubin is uptaked into the hepatocyte and then conjugated there and then excreted from the biliary system and into the intestine. And the urobilinogen then may come back, uptake into the hepatocyte or excreted from the kidney. But mostly the urobilinogen is excreted from the feces. So in our patient, the patient has unconjugated hyperbilirubinemia. And on the contrary, there is conjugated hyperbilirubinemia. These two are two types of hyperbilirubinemia. The unconjugated type may be related to three reasons. First, there may be overproduction of the bilirubin, which may be caused by hemolysis. Second, there may be reduced uptake of unconjugated bilirubin from the hepatocyte. And three, the patient may have a conjugation defect, which leads to too much unconjugated bilirubin. And as for the conjugated hyperbilirubinemia, the product is here. So there may be hepatocellular injury, which causes conjugated hyperbilirubinemia. There may be intrahepatic cholestasis, or there may be extrahepatic cholestasis, which reflects ineffective excretion, which may be related to biliary obstruction. Okay, so biliary obstruction means from the hepatocyte out to the intestine. Anywhere through this biliary system, there may be an obstruction. So back to our patient. Our patient is a mainly unconjugated hyperbilirubinemia. And as I had mentioned previously, there are three types of etiologies: overproduction, reduced uptake, and conjugation defect. Overproduction is mostly due to hemolysis. Reduced uptake is due to drugs sometimes. And conjugation defect, there are some maybe acquired causes and some are inherited causes. So hyperthyroidism is a possible cause of conjugation defect. And inherited causes, there are syndromes such as Crigler-Najjar and Gilbert syndrome. And here's a kind of a mnemonic as well. So inherited conjugation defect, there are ICGs, Crigler-Najjar for C and Gilbert syndrome for G. ICG is a test you use for liver function, right? So ICG, inherited conjugation defect, is Crigler-Najjar and Gilbert syndrome. Okay, so this is unconjugated type, right? So what about the conjugated type? There are also some syndromes that cause conjugated hyperbilirubinemia. And defective excretion is the etiology, and the diseases are Dubin-Johnson syndrome and Rotor's syndrome. So here's a kind of a mnemonic for the conjugated one: defective excretion and conjugated hyperbilirubinemia. There is Dubin-Johnson and Rotor syndrome, DDR. Okay. So back to this patient, we see the lab data summarized here. The patient does have anemia, though it's microcytic anemia, and the patient has isolated indirect type hyperbilirubinemia. So what will help in your differential diagnosis? Will an abdominal echo help? Will thyroid function help? Will haptoglobin LDH reticulocyte count help your diagnosis, or all of the above? Actually, these are all etiologies that I just mentioned to you for hyperbilirubinemia. The abdominal echo you can use to evaluate if there is biliary tract obstruction. Thyroid function may cause indirect type conjugation defect. And the haptoglobin LDH reticulocyte are lab tests for you to help differentiate the patient if the patient has hemolysis. So our patient, the echo was done and the biliary tree was normal. There was no obstruction or biliary tree dilatation. Viral hepatitis survey was negative, and the thyroid function, free T4, TSH, and T3, these lab data were normal. Hemolysis workup, reticulocyte 1%, LDH, heptoglobin were normal. So bilirubin decreased after the patient was managed well. The patient was admitted for appendicitis, right? Bilirubin soon decreased as well. So actually, this patient, our impression would be Gilbert syndrome, because Gilbert syndrome is an inherited conjugation defect, and the jaundice may be triggered by dehydration, fasting, or hemolysis, or febrile illnesses. For example, acute appendicitis. The patient was febrile, right? And other may be related to physical exertion or stress. These all may cause the aggravation and triggering of hyperbilirubinemia in Gilbert syndrome. But usually this is a benign condition and the bilirubin returns back to normal after the event has passed. Okay, let's talk about this next case. This is a 56-year-old man with history of gallstones and presents with right upper quadrant pain and fever up to 38 degrees. Okay, so this patient has fever and right upper quadrant abdominal pain, and he has a clear history of cholelithiasis. And when you perform physical examination, you see that the patient has frank jaundice. The sclera is icteric, the right upper quadrant, you palpate, there's tenderness, and you see that the AST is 162, ALT is 184, the total and direct bilirubin are 5.4 and 3.5, alkaline phosphatase is 524. The prothrombin time is normal. So you can tell that this is a cholestatic pattern, and the bilirubin is mostly the conjugated type, although the unconjugated is also elevated, but usually we just call this the direct type hyperbilirubinemia. So when you see this patient, we discuss the bilirubin metabolism. For this patient, we have to focus on the conjugated type and the causes here. So review the causes: hepatocellular injury, intrahepatic cholestasis, or extrahepatic cholestasis, which indicates biliary obstruction. So this is a summary of the approach to a cholestatic person with conjugated type. First, you might want to do an abdominal echo to evaluate the biliary tree. If there is biliary tree dilatation, there is duct dilatation, that may indicate biliary obstruction distal to the dilated biliary tract. And for intrahepatic cholestasis or hepatocellular injury, they may be related to hepatitis, cirrhosis, drugs, sepsis or post-operative status, or there may be also primary biliary cirrhosis. Now it's called primary biliary cholangitis now. So in our case, we approach a patient with cholestasis. As you can see here, this is the gallbladder. You see some stones, and there's IHD dilatation and biliary tree dilatation. And here, this is the common hepatic duct. And as you can see, these with shadows, acoustic shadows behind, these are the hallmarks of the gallstone under ultrasonography. And here, this CHD, there is a stone inside as well. This is a very clear image of a demonstration of a CHD stone. So there's a CBD stone here, and the biliary tree is diffusely dilated, and the patient does not have a Murphy's sign. Murphy's sign is indicative of cholecystitis. So this patient is a negative pro-Murphy sign, and this gallbladder, it's not swollen or with perigallbladder fluid collection. So you probably have the impression of CBD stone with cholangitis, right? So cholangitis, and the patient, nowadays we can perform ERCP. This is a endoscopic procedure. It's a retrograde cholangiopancreatography. Usually we perform this to approach the biliary tree with stones or strictures. And stone retrieval was performed during this procedure. And then, but the cause of this cholangitis, the gallstones, these need to be managed as well, because next time if the stone comes out of the gallbladder and gets stuck in the CBD again, then this patient will have recurrent obstructive jaundice and cholangitis. So the patient later, 2 months later, received an interval cholecystectomy. Okay, next, let's talk about this other patient. A 60-year-old female patient with jaundice and body weight loss. The body weight loss is clinical significant. There's 5 kilos loss of 5 kilos in 2 months. Otherwise, the patient was asymptomatic with good performance status. All you see from physical examination is that the sclera is icteric. And the lab data shows you slightly elevated AST/ALT, bilirubin up to 10.8. The direct type is 7.2. So this is direct type and a cholestatic pattern. Alkaline phosphatase is 524. The PD is normal, borderline slightly elevated. So we have the experience from the past case. From the previous case, we arranged an abdominal echo for this patient as well, because we know there may be a cause of obstruction. And as expected, we see that the patient has diffusely dilated biliary tree. The IHD and the biliary tract are all dilated. However, we do not see, as the previous case, gallstones or CBD stones. There's only diffusely dilated biliary tree. So here we review the anatomy of the biliary tract and the outlet. Here there is the gallbladder, the common hepatic duct, CHD, and intrahepatic. Okay, and outside here, after the cystic duct, this is the CBD, and the CBD goes into the pancreas and joins the pancreatic duct, and then at the ampular vater, the opening at the duodenum second portion, the papilla, these two join and excrete bile and pancreatic juice from here into the small intestine. So actually, if you see diffuse biliary tree dilatation over here, the obstruction level could be anywhere below the dilated biliary tract. So anywhere here at the papilla, at the pancreatic head, or here in the CBD, anywhere they may cause diffuse biliary tree dilatation. So this patient, you see biliary tree dilatation, you know there's a site of obstruction, but there is no obvious stone like the previous case. So you arrange an abdominal CT, and has associated body weight loss. Body weight loss may be indicated as maybe suspective of malignancy. And so you check for the some tumor markers, and you see that there is an elevation, and the CT shows a pancreatic head mass. So what is the impression here? The impression is probably pancreatic cancer. Okay, next, let's talk about, oops. Okay, next, let's see the next case. Okay, a 55-year-old female patient with generalized pruritus, icteric sclera, dry eye, and dry mouth for 2 months. The physical examination, you see jaundice as well. Okay, so the lab data here is more similar to the first case, the first cholestatic pattern case we discussed. The AST is 102, the ALT is 75, the direct type bilirubin is 5.4, direct type is 3.5, total bilirubin 5.4, excuse me. The alkaline phosphatase is 524, and the PT is normal. So we know that this is a cholestatic pattern, right? So we are experienced, and we know that the first step we do is arrange an abdominal echo to see if there's an obstruction. Well, but this case, you see that the biliary tree is normal, and there's only mild parenchymal liver disease. The parenchyma seems a little bit coarse. There may be mild fibrosis. Okay, so the biliary tree is normal. This is not like the previous two cases where you see a dilated biliary tree and you try to find a level of obstruction. This is not the same. So what was the other area that we need to make further differential diagnosis, intrahepatic cholestasis or hepatic injury. So you need to work up further such as hepatitis, cirrhosis, drugs, or sepsis or post-operative status, PBC, primary biliary cholangitis, and how do you diagnose this? How do you diagnose this? This is by ANA and anti-mitochondrial antibody, AMA. So for the patient, you perform the workup as well. So the anti-HAV, IgM, HBs antigen, and anti-HCV antibody, these are all negative, meaning that patient does not have viral hepatitis. Anti-smooth muscle antibody, negative. This is for autoimmune hepatitis survey. The iron survey for hemochromatosis is negative. CRP, procalcitonin, to see if the patient is related to infection or unstable hemolysis, this is negative. These are all normal values. And the anti-mitochondrial antibody, AMA and ANA, are both positive. And this is quite sufficient if combined with the lab data that your impression may be primary biliary cholangitis cirrhosis. So these are some clinical cases that I shared with you and approaching the different types of hepatocellular injury pattern. And this is just a brief introduction, and there are quite a lot of topics here that need further approach, but this is the general approach for you to when you first meet a patient with hepatocellular injury, and some of the important questions of key history you need to ask when you approach the patient. And this will end my talk, and feel free to ask any questions in the chat section. The slide, I will send the full version after class, because the previous slide I gave, there was only the questions without answers to the slides, and I'll be sending a full version later, so you can have the slides as well.
Okay, thanks a lot, doctor.
Okay, so if there is no more questions, I guess that will end our session here. So maybe hope you all have a happy learning.
Okay, thank you.